Okay, we're going to go ahead and get started. We're at the top of the hour here. So thanks for joining us. I'm Tim Anderson, one of the senior research analysts at Bank of America, and this is a 40-minute fireside chat on emerging treatments for lung cancer, where there really is a lot of exciting stuff happening, and I think where the science has cracked open over the last decade or longer. I'm joined on stage by my colleague, Alec Stranahan, to my right, who's also a senior research analyst covering the biopharma space. And together we'll be talking with a few of Mass General Brigham's best experts in the area. This includes Justin Gainor, who's the director of the Center for Thoracic Cancers at MGH, director of targeted immunotherapy in the Henry and Belinda Termeer Center for Targeted Therapies at MGH, a co-leader of the Dana-Farber Harvard Cancer Center Lung Program, and associate professor of medicine at Harvard Medical School. We have Dr. Rebecca Heist, who's associate director of clinical research at the Mass General Hospital Cancer Center, a member of the Thoracic Oncology and Termeer Center clinical research groups, and a professor of medicine at Harvard Medical School. And then we have Zosia Petrosky, who's a lung cancer medical oncologist at Mass General and assistant professor of medicine at Harvard Medical School. So I thought we would approach this by category or really by mechanism and class of drug, perhaps. And we'll emphasize mostly pipeline drugs because this is the conference about innovation. So with that, why don't we start with bispecifics in a couple of areas. So in the news, and certainly on investors' minds, are these PD-1 VEGF bispecifics that have gotten a lot of attention. And we've seen a handful of companies that we track closely in the space. Summit is in the lead with their compound, ivonescimab, and then BioNTech and Bristol have partnered up. We've got Merck that in-licensed a Chinese compound recently, and then Pfizer as well. Maybe we can just start your level of excitement with this approach. We have had some recent data, so looking at the underlying biology, what we know about VEGF and lung, the recent data sets, how are you viewing this class of drugs?
Yeah, I can get started there. So, VEGF we know has played a role in lung cancer pathogenesis, and we know that VEGF inhibition is active in lung cancer. We know it boosts response rates. The monoclonals had fallen out of favor, but as you mentioned, now there's this resurgence of the bispecifics. I think the data that we have so far, I would break it down into EGFR space and then the wild type space. What got most of our attention was among EGFR wild type patients in a head-to-head against Pembro. Showing a significant improvement in progression-free survival with a hazard ratio around 0.5. So I think that definitely gets our attention. I think the critical question is whether that's going to translate into OS. My sense is that it's not going to be an overwhelming OS benefit if we see it. I think it'd be more in the 0.8 range for hazard ratio. We're still waiting on that data though. And I do think 0.8 would be, clinically meaningful. And the other piece that is important to note is that it looks like the safety profiles of the bispecifics are better than the monoclonals against VEGF. So a few key points there is the half-lives of these drugs are much shorter, and we didn't see, at least in the Summit data, as many bleeding events, despite them enrolling kind of large central tumors. So that was a bit of a surprise to us in the field.
Anyone else?
I can maybe just add, I think specifically in the EGFR space, there has been a lot of interest in these compounds. I think, EGFR mutant lung cancers have previously been shown to be, sensitive to VEGF inhibition and, that VEGF pathway being particularly relevant. I think, the data from the Harmony A trial was was mixed. I mean, I think it was positive for one of the co-primary endpoints, PFS. Never, you know, didn't meet the mark for OS, but it was a complicated design with kind of the majority of the patients accrued in China and then kind of a later addition of ex-China patients. And so I think the jury's still out on the role. I would say that in the EGFR space, and we'll come back to this, you know, we've had a lot of success with the amivantamab, you know, we've chemotherapy with TKIs, but I think novel therapeutic agents there are important. And so whether, you know, in the end, the ivonescimab data will be enough. Maybe, you know, maybe not with the OS not meeting its endpoint, but certainly I think there's an appetite for other compounds, as you would say, in this space. And I think there too, the half-life is an important factor because we've always been worried about the reintroduction of targeted therapies in patients who've had prior exposure to checkpoint inhibitors. And there's a thought, although not yet, I think, really established in the clinic, that perhaps the shorter half-life of these may abrogate this concern that there's increased targeted therapy toxicity if a patient has had a PD-1 or PD-L1 inhibitor and then immediately goes on to TKIs. And that, I think, has been a big source of hesitation for really using the immunotherapies, in addition, of course, to the lack of efficacy of PD-1 or PD-L1 inhibitors on their own without the VEGF component.
And I think in that space it'll be really interesting because we have historically not been able to use immunotherapies well in the EGFR space and many of the oncogenic driver spaces. And so if this combination of VEGF and PD-1 is able to allow the introduction of immunotherapies in that population, that to me is a benefit.
Yeah.
I think one lesson though is that while there's so much enthusiasm, like, you know, everyone doesn't want to miss out on the next PD-1. I think unfortunately that's led to some bad trial designs, and I think the Harmony study is one example of where they had already designed and read out the data from China, and instead of opening a separate global study, they instead amended the protocol, then enrolled a Western population where they'd already looked at the data, right? And so the statistical assumptions, readouts, you know, are compromised in that, you know, rush for speed. I think in the end, it's actually led to kind of interpretations by academics is the data was not as robust.
And would you, so Justin, you mentioned you thought OS hazard ratio of 0.8 would be good enough. Do you agree as well, Zosha and Rebecca?
Yeah, I think, you know, I think we've already seen PFS, which I think is also a clinically meaningful endpoint. Yeah. You know, of course, OS is always our gold standard, but I think 0.8, you know, statistically significant, meeting the bounds of statistical significance, I think so.
I think so too. I mean, but it depends on which population,
Yeah.
right? So in the wild type population, if you meet that OS of 0.8, yes, certainly in the highs. In the 1 to 49s or less than 1s, are we really using pembro monotherapy? You're going to ask yourself, what does that compare to with a chemo IO regimen? And then I think in the EGFR space, that's very complicated. How exactly are we going to be using platinum chemotherapy in the future? Is it going to be a second-line regimen, or will it be moved to first line? And then what does that data mean in terms of how we incorporate ivonescimab in the EGFR space? So I think there's a lot of flux in that space.
The reason I asked the question is the investment community looked at that hazard ratio that most recently out of Harmony, it was 0.79, so right at 0.8, and was very disappointed with it actually. So it's interesting to hear that you think that data would actually be adequate.
Well, I think one piece is you know, what's doing the heavy lifting? Is it the PD-1 or the VEGF or some synergy between the two? You know, I think, you know, VEGF probably is playing a bit of a role there, and which is why, you know, hazard ratios in the 0.7 to 0.8 range is probably what we're going to see. But that's still a benefit, right? You know, when you look at ASCO guidelines of what has historically been deemed worthy of kind of implementing it, you know, 0.7, 0.8 is in the range of what we would expect. And I think we've gotten spoiled in lung cancer over the last 10 years, right, of seeing all these hazard ratios like 0.2, 0.3, 0.5. I do think this is a bit incremental, but it's still a benefit to our patients. So to me, I think it would be adopted clinically, at least in the US.
And I would just add, and I know we probably have to move on, but if we look at another example of a study with actually a surprisingly similar, and albeit interim analysis, Mariposa 2, the chemotherapy amivantamab, the numbers and the hazard ratios, they haven't had their final OS readout yet, but the numbers so far look strikingly similar, and we don't have final OS data, and yet that's been widely adopted, I think, for patients. And so, I think that it is context dependent, and really, we don't have so many options for these patients in later lines of therapy. So I think the clinical reality is we can't really afford to be too choosy about, if something has an OS benefit, I think it's meaningful.
Yeah. Okay. So on the BioNTech and Bristol compound, pembrolizumab, they pair or they hit a PD-L1 epitope instead of PD-1. Any a priori reason to think that that would lead to a different clinical profile? I guess when we look at least at all the clinical data comparing just the standalone PD-1s and PD-L1s, they look, quite similar. I'm not sure there's really much of a difference.
I would agree with that. I think that of the 50-odd PD-1, PD-L1 inhibitors that are approved or in development, they're remarkably similar. Maybe if you do large-scale meta-analyses, a couple percentage points difference in terms of tox profile with the PD-L1 inhibitors, but not enough to justify using one class over the other clinically.
Okay. Do you have any questions? on that,
Just on that asset specifically, they've got a phase 3 study ongoing in frontline ES small cell lung cancer. I guess, what would you sort of look for in this setting for frontline adoption?
We would need to see an overall survival benefit. I think it's going to be, the response rates upfront to treatment in small cell are quite high. So initially, high response rates are not going to be that telling. I think we really want to see an OS benefit for adoption.
I would add scientifically, checkpoint inhibitors in small cell have produced relatively modest benefits, right? Yes, they improve survival, but minimally slow. And I think some of that stems from the biology of small cell lung cancer, where you actually have a lot of downregulation of antigen presentation. And so that's kind of hard to reinvigorate host immunity there. To me, the T-cell engagers, things like bispecific, the bispecific tarlatamab, that's produced a much more noteworthy benefit in the second line setting. So, to me, I think I could envision a spot where the T-cell engager gets inserted in first line therapy somehow as being much more likely to give a bigger benefit than a bispecific VEGF. But it's how do you sequence it? Do you do it like at the start or maintenance? I think you'd probably need to think about it as maintenance.
Great. Okay, I want to shift to a different bispecific, which is EGFR MET. So this is J&J's Rybrevant or amivantamab. How do you use this product in your practice currently, especially as it's gotten approval in frontline versus later lines, which is what the initial approval was for?
Yeah, I can start. I think it's truthfully a complex question, because I think there's no doubt that this agent has activity in EGFR mutated lung cancer. I think that is not questioned, but at the same time, it has quite a bit of toxicity and a different safety profile than other agents that we're used to using, particularly, TKIs as monotherapy or even a TKI chemotherapy combination. And so I think overall as a field, we've struggled as to exactly when the right time to kind of take on those toxicities for patients is. I think, the frontline Mariposa data is certainly strong in terms of efficacy. It was the first of these frontline EGFR trials to show a survival benefit, although now we also have a survival benefit in the chemotherapy combination with FLAURA2 as of a few weeks ago. I think as a field, there has been some hesitation to use amivantamab frontline just because of the duration of time that patients have that are on that therapy and the toxicities that go along with it. I think, I would personally be comfortable using it for young patients who really, want a therapy that gives them maybe the most options later line. That's another factor that plays into it. But I think in general, it is something that I've leaned more towards for many patients reserving to later line therapy, whether that be in chemotherapy, combination, a second line, the Mariposa 2 regimen. There's also activity, although it's not approved, even in post-chemotherapy. You know, amivantamab lazertinib has activity in the post-TKI, post-chemotherapy setting, although that's not an approved indication right now. So I think that it's still an open question, and I would say the adoption of frontline amivantamab lazertinib has not been, I think, even probably quite as robust as the TKI chemotherapy combination, which many of us would consider more tolerable for patients.
Yeah, and I think now with the FLAURA2 OS readout, it kind of calls into question how much additional adoption there would be, because I think people will feel much more comfortable with the combination of chemo with the TKI upfront. I mean, that's an area that is kind of calling out, begging for some biomarker so that we can better choose how to start. Because I think we all have patients who, you know, we started osimertinib on 5 years ago, and now they're still doing great with no progression, and their quality of life is great. And if you could tease that out and say, for you, we don't actually need to escalate treatment, and we have a pill that's going to be reasonably tolerable, certainly easier than chemo combination or Amilaz, we'd prefer to start that way, and then reserve these other drugs, which do have definite efficacy, but certainly toxicity for later line. But we don't know how to do that right now, and we need to know how to do that.
Yeah, I think as we think about innovation, I think this is a, you know, a prime area where you create a new paradigm. And to Dr. Heist's point, you know, I think there are two approaches that you could take here. One approach is, at baseline, are there various omics, clinical characteristics that we can build a model to say this patient's at heightened risk and needs combination therapy, or this patient is low risk, we can just do monotherapy. That's one approach. Right now, it's been fairly rudimentary, the things we've looked at as a field. The second approach is to say, we're not smart enough to do that, let's look at a functional readout, something like ctDNA, you know, after a few weeks to see the quality of the response and then intensify or de-escalate from there. Again, we're not there yet, but I think those are the types of trials that we need to be thinking about. It does, though, you know, we need better technology, because using a simple ctDNA assay that's just, you know, tumor uninformed right now isn't good enough to give us the dynamic range that we need to make that escalation, de-escalation decision.
There's a sub-Q formulation in the works that would greatly simplify the regimen, and also it seems to actually substantially improve tolerability. So when that launches, which could be, I don't know, maybe this year, by next year for sure, will that meaningfully change how you use the product, or not necessarily?
I think it will help, but I think it won't eliminate all of the issues that we're really dealing with in the clinic. It will specifically help with the, you know, essentially eliminate the infusion-related reactions or significantly diminish them. You know, I think it's going to eliminate the need for the split dosing over the first infusion, which is an important factor in terms of chair time and kind of healthcare utilization. Those are the biggest advantages. I think it does not, unfortunately, impact some of the more long-term toxicities that really, I think, are the biggest kind of concern that we have for patients, the dermatologic toxicities, the scalp issues, the risk of VTE, and all of these things. So I think it will help. It won't be a game changer. There are interesting signals in the Paloma-3 study of perhaps slightly better efficacy with the sub-Q formulation than IV that I don't think any of us can really fully explain as to, you know, mechanistically why that would be the case. And, you know, I think if we saw that play out, there are some follow-up studies ongoing with sub-Q amivantamab. That would be important, but overall, I think it's a good to have, but not a game changer.
Yeah. Okay, and then in your view, is there a role for this in adjuvant at some point? Because we certainly have Tagrisso in adjuvant through trials like ADORA and LAURA, different risk-benefit profile in that patient population. Mike, I think I can guess how you'll answer that question.
You know, the adjuvant setting is completely different, right? So people are cured. So, well, some people may be cured with just what they've had so far alone. And then I think what we've experienced in the adjuvant setting is that a drug that we think is very easy to use, like osimertinib in the metastatic setting, is actually pretty challenging in the adjuvant setting. The toxicities just seem to be heightened. The kind of acceptance of some level of detriment to your quality of life is much less in the adjuvant setting than in the metastatic setting. And so I've had conversations with people when I'm giving OC in the adjuvant setting of like, can you continue this? Will you consider continuing this? And I think the toxicity profile in that setting is going to be hugely important for the adoption of any therapy in that space.
And I completely agree, and I'll be very blunt. I would see no future for that as an adjuvant therapy. It's just too toxic, and I think the benefit would be incremental.
The one counter argument I would add is I totally agree in the adjuvant setting, but what about a neoadjuvant? I think like a shorter time preoperative, I'm skeptical. I think many of the same considerations apply, but I think that we are not doing very well with neoadjuvant approaches in the TKI space. The NeoAdora study showed actually very low rates of pathologic complete response. And so I think we need different strategies there if we were to take a neoadjuvant approach. And so I think that's the one kind of potential avenue where a short course, perhaps, the toxicities would be a consideration. Again, I think even there it may be too toxic, but I think that's the one space where potentially, I think years and years of this agent in the adjuvant setting when we know that many patients may not need it, is really hard. But a shorter preoperative course is something that I personally would be intrigued by, although I don't know what that would bring.
Okay, a couple of really quick questions, and you could answer these in an abbreviated fashion. So Astra has two bispecifics. One is a PD-1 CTLA-4, the other is a PD-1 TIGIT. We know CTLA-4 has activity in lung, and we've seen some early data in frontline lung from a couple of years ago that looked good. They had efficacy, tolerability was quite bad. They had to cut the dose down. Your thoughts on the viability of that program in as much as you have a view, and then also the PD-1 TIGIT, where we don't have much data?
Yeah, briefly, I would say that CTLA-4 has had a bit of a comeback in lung cancer over the last several years. It's not going to be an all-comers drug or approach. We find, particularly in the low PD-L1 expressors, that's where you can derive a lot of benefit. Value of the bispecific. One caveat of that data that was presented several years ago at ESMO is the follow-up time was relatively short. And so while it looked a little bit better from a toxicity standpoint, I worry that we're just not seeing long-term follow-up. So I think it's going to be hard-pressed. I think it's going to be a very incremental improvement, and I think it's going to, if any, and so we just need to see more data. And TIGIT's, had a roller coaster ride of emotions in lung cancer. I would say that people are relatively low on TIGIT right now because so far, at least with the monoclonals, we haven't seen OS benefits.
I think with the TIGIT, the question of is the bispecific and then the FC reduced, will that be a substantial enough change? So we'll have to see.
Alec, did you want to?
I've got one question on PD-1, and it's kind of a sidebar, but when you think about a future where we maybe have a biosimilar Keytruda, I don't know if that's 2028 or sometime after that, how do you see these bispecifics playing in? Do you always choose the most efficacious product in that scenario, or is there actually a cost-benefit calculation that would need to be done?
I think in the US, the clinician doesn't feel the cost necessarily, right? And so we're not incentivized to choose the cheaper option. We're going to go with what we think is the better, from an efficacy and safety standpoint. At least that's the current state, right? If you start implementing pathways and things like that, maybe. But you look at cemiplimab, has that moved the needle with the lower cost? Most institutions are still not using cemiplimab as their first-line therapy.
Do you want to ask about RAS and that topic?
Yeah. So with the advent of molecular glue assets, I think there's been a resurgence in excitement around shutting down the RAS pathway with daraxonrasib, zelironrasib, elironrasib. I guess maybe to tee things up, how has your experience been with KRAS therapies like Lumakras from Amgen or Krazati from Bristol Myers, and how might next-gen approaches, including molecular glue assets from RevMed, maybe change things?
So in KRAS, the G12C allele-specific inhibitors were a huge advance, right? It used to be that KRAS was undruggable, this was not a target, and the fact that in lung cancer, where that's a quarter of patients who have KRAS mutations and about 12% in general with G12C, the fact that you can target that is a huge advance. I think in general, we've been a little disappointed by the level of activity. If we think about a targeted treatment, where generally we've gotten used to in lung cancer response rates in the 60 to 70% range, you're living for years, and that is not what we see with the G12C inhibitors. And so there's definitely an appetite to see how we can make that response and that durability of response better. I think it speaks to kind of the complexity of the KRAS lung cancers and the heterogeneity we see in them, both genomically and otherwise. The new inhibitors, the pan-RAS, pan-KRAS, some of the on-state inhibitors, the GLU, all really interesting, and then also have the potential, of course, to expand not just G12C, but G12D, and then the other alleles that are altered. So I think this is a space where there's a huge amount of potential and movement. We will have, I think, G12D inhibitors in clinic very soon, and then perhaps pan-KRAS inhibitors. I think across the board, we know that KRAS isn't quite the target that EGFR ALK-ROS is, right? These are kind of somewhat more complex tumors in terms of that tumor milieu, but this is also an area where as technology develops and drugs get better, I expect to see that we'll have better treatments.
Yeah, I think RevMed showed maybe a 10-month PFS and an 18-month OS in second, third-line patients with daraxonrasib monotherapy. They also showed 86% ORR and 100% disease control rate in frontline TPS greater than 50% when combined with Keytruda. Obviously, this is early phase 1 data, but how does this kind of stack up to standard of care in your view? And is there maybe a path forward for a subset of patients to combine in the front line with Keytruda?
Yeah, I mean, I think certainly in the front line, there's a lot of interest in a lot of studies looking at KRAS inhibitors of various types combined with IO, sometimes chemo IO, to see if it's better than the standard. We'll see how they read out. If they read out as positive for OS, they will certainly get approved. And we may be seeing more changes in how we actually treat in the first line setting for that subset in the future.
It's always a bit challenging when you're talking about a phase 1 study and a first line patient enrolling in that phase 1 study, right? It's always going to be a skewed subset of patients, right? Because in order to enroll, in that study, generally those are patients who can wait several weeks to start therapy, right? So their disease biology is going to be a bit better, right? Especially for an early phase study, right? So I think it's encouraging, but I don't think we can compare that to then registrational phase 3 studies and say, hey, this is going to be that, this is the next thing. So I think that it's going to come down to, how well does your RAS inhibitor combine with PD-1? And we've seen already, some drugs combine, some don't. Sotorasib we know does not because of hepatotoxicity. So, I think we're going to have to do those studies because it's not a class effect. So we're going to have to look at each drug individually. How does it combine?
Maybe one more question. Just when you think about shutting down the RAS pathway, I think to your point, it is very complicated, and there's a lot more maybe escape mechanisms within that pathway. We've seen plans from several companies to do triplet type combinations with a CPI plus a pan-RAS and a, say, G12C specific inhibitor, which is maybe the efficacy driver on the RAS side, and the pan-RAS is kind of reducing the escape mutations. Is this a viable strategy? Is this maybe too many in the combos? Are they trying to get too cute? Maybe.
At the end of the day, some of this will come down to also toxicity profiles, and certainly when you start to add the pan-RAS or pan-KRAS, you end up adding to toxicity, and that may or may not be feasible in the long run. And then there are pathways outside of RAS actually that get activated as well, right? So in colorectal, certainly it's EGFR pathways getting activated, and in non-colorectal as well. So ultimately, at the end of the day, it's going to be tricky to really try to shut down every bypass tract that can get activated when you're shutting down KRAS. And These combinations, I think, are certainly worth pursuing to see if it will increase efficacy, but we're going to be looking carefully at the toxicity profiles because that will matter a lot as we think about how can we adopt these.
Okay, let's shift to antibody drug conjugates if we can. And I thought I'd start off with the TROP2 category. You've got a couple of products now in the market. We've got Gilead's Trodelvy, which was the original one, and then more recently AstraZeneca has Datroway. We have Merck investing in, I think it's 15 phase 3 trials now with their program as well. When I look at the breadth of clinical trials across these 3 products, it's a lot. And from where I sit and from the data we've seen, to me it still feels like there's some question marks with this class, depending on the tumor type. We know there's clear activity in breast. We know there's activity in lung, at least in late-line lung. I guess the starting question is in frontline lung, which is really where the money is if you're a drug manufacturer. What's your view of the data thus far and the approach and the mechanism, the experience?
So the TROP2 ADCs certainly have activity. We've seen good activity with many of them, and we are always happy in the lung cancer world when we see a drug that has activity because we always need more drugs. They do come with toxicities, and they're a little different depending on the specific ADC. I think one of the big questions in the first-line setting, and there have been many studies, as you know, a whole army of studies, is that really going to be something that is going to be tolerable in the first-line space? And I think we've talked about this a lot, actually, where as you're starting treatment for lung cancer, you definitely want the efficacy, but to hit people with a ton of toxicity up front is actually pretty challenging. And so I think that's one of the big questions. What's been reported so far are pretty early phase 1b studies. Those data you always take with a grain of salt because they are highly selected people who go on to those studies. And then ultimately, at the end of the day, you're going to need to look at a phase 3 comparison with the standard of care, which happens to be, as IO or chemo IO, pretty tolerable. And so we're going to want to see an OS benefit, and we're going to want to see that the tolerability is there. And that's a pretty high bar. So jury's still out. I don't know how that will pan out. I would say for the TROP2 ADCs, there's certainly activity. I'm thrilled to have them. I don't know if we'll make it in the first-line space.
And I think akin to what we were talking about with amivantamab in the EGFR space, when you have, particularly in the frontline setting, when you have agents that have activity but toxicity, once again, it begs for a biomarker, right? I think if we had a better sense of which patients are really benefiting from these therapies, and I know we'll probably come back to this question, but I think that would really, make it a much easier kind of thought paradigm in the clinic of, okay, you have a patient, they have a biomarker that really tells you their tumor is going to be sensitive, then it's perhaps worthwhile to take on those toxicities, whereas kind of an all-comer approach without that becomes a lot harder to implement when the other options are frankly better tolerated.
Yeah, completely, because the phase 3 studies against second-line docetaxel were negative on OS, right? So in that setting, will it really beat in the first-line setting? IHC of TROP2 itself has not panned out as a biomarker. There is a lot of interest in this QCS, NMR QCS biomarker, which is kind of a measure of membrane over total TROP2. And if that pans out, I do agree, like if you knew that there was this subset that was going to have remarkable benefit, then picking out that subset in the first-line setting would make sense to do. But it is something that's just asking for a biomarker.
And what is your view of QCS NMR? So that's the proprietary Roche Astra biomarker that you just referenced, and it's only being incorporated into the Astra trials because it's proprietary. So we're not seeing the others able to use it. They're using just conventional IHC and other ways to determine TROP2 expression. So based on the data you've seen, what do you think about that biomarker approach?
I mean, it's been mostly retrospective, and so in retrospective analyses, it's been able to differentiate, and you see the Kaplan-Meier curve separate. I think, at the end of the day, prospectively, can it really differentiate out a group that's going to have a 60% response and really prolonged PFS and OS versus 10% response? I think we need to see that. I think it's a doable biomarker, and I think if it did show up, if it did end up showing data to that extent, I think it would be something that could be adopted. Many biomarkers start off proprietary, and then they get adopted, and people figure out how to make it work for a broader swath of drugs or populations. So I think if it ended up showing that differentiation, it would certainly get adopted.
All three of the companies claim to have a best-in-class product, which is not unusual. When we look at differentiation between the molecules, I guess we see it most on tolerability at the moment, because you have Astra's, for example, that causes interstitial lung disease. You've got Trodelvy that seems to cause more frequent GI adverse events. Does anything jump out as best-in-class to you among the three?
Not really. Not really.
And do you think they'll differentiate on tolerability more than, will that be the decider?
My sense right now is the tolerability comparisons that we're all doing in our head, is not amongst them. It's are you going to be more tolerable than the standard platinum doublet chemotherapy, which, for many of those drugs, things like pemetrexed, you don't see alopecia, it's well tolerated, it has some CNS penetrance, you don't see high rates of ILD, right? So that's to me, that's the more apt comparison, because, for a drug, even if it's like barely beating docetaxel, like that's not going to be enough from an efficacy standpoint to override things if there's excess toxicity.
Yeah, and that's exactly right, because right now in the first-line setting, when we talk about chemo-IO in the non-squamous setting, right, people are so pleasantly surprised when they don't lose their hair, and the tolerability of that regimen is actually really, really good. So, that's exactly right. The comparison is to the standard of care, not amongst them.
Okay, couple of rapid-fire questions. So Pfizer has two ADCs, not TROP2, but they're vedotin-based ADCs. One's called sigvotatug vedotin, which hits integrin beta-6, and then they also have a PD-L1 vedotin bispecific. Any familiarity with those? They really kind of leapt from phase 1 to phase 3, leap of faith in a way, at least how I look at it. What are your thoughts?
Too fast. I mean, the data, the phase 1 data for the integrin beta-6, I would say there's some activity there, but, for a response rate around 20% or so, if it was my money, I would not be jumping to a phase 3. I'd try to get a better sense of where are the subgroups that are going to benefit most. PD-L1, ADC, I think is an interesting concept. I do have some mechanistic concerns, right? Because we know PD-L1 is not just expressed on the tumor, it's also expressed on, antigen-presenting cells. So is there a world in which I may blunt my anti-tumor immune response too? So I think we just need to see more data.
Great, okay, and then moving to checkpoint inhibitors. So lots of disappointment in terms of looking for next-gen agents. We have one outside of the PD-1s, which is LAG-3, approved in melanoma. We've got both Bristol and Regeneron that have LAG-3s in lung. So the question is just your view of the strength of the evidence that's going to say there's going to be a role for LAG-3 in lung, but they're in frontline studies.
Yeah, I mean, I would say what we've learned is using checkpoints after PD-1, very minimal activity. So LAG-3 after PD-1 really doesn't work. I think the initial studies in lung cancer were using lower doses of LAG-3 with the Bristol drug, but they've since launched studies of higher dosing akin to the melanoma. I would say right now, I've not seen convincing evidence that LAG-3 plays a role in lung from an efficacy standpoint.
Okay, and then last question is in the vaccine space, and I wanted to ask about one particular product, and then if anything else you guys would like to point out. So Merck and Moderna have V940, and that's farthest along in melanoma, but it's also in a lung study as well. I guess the question I have is we've actually seen some very compelling results in melanoma from a non-registrational data set, but it's essentially a mini phase 3. They need to run a larger trial, and they are. We've seen some activity in lung. What's the prospects of this product in lung? And what's the read across? If it works in melanoma, can you kind of assume it might work in lung? I know melanoma is highly immunogenic.
Well, I would say both lung and melanoma belong in that sphere of highly immunogenic tumors, right? Because they're driven by different carcinogens. So, to me, I was really encouraged by the melanoma data, right? It looked like a very strong relapse-free survival benefit, and so I think that's really encouraging that may play out. It's just but what's clear is this is not going to be like a drug for metastatic disease up front. I think vaccines are really best positioned in the adjuvant setting.
Any other vaccines on the horizon that look promising?
I think other people are trying. One of the downsides of V940 is it's personalized, right? So it's more logistically complicated to produce. Other approaches, using mRNA technologies are trying to target tumor-associated antigens, like shared tumor-associated antigens. I think while that's a path forward, we haven't seen any data there, but at the same time, they're not entirely specific. And so they have the advantage of being off the shelf, which is an advantage, but in terms of immunogenicity and the meaningfulness of that, I think is lower than if you were to use a personalized approach. But it still may lead to benefit. We just haven't seen any data.
And I would say that, I think there's a lot of interest and excitement for these informed vaccines, and it depends on the operationalization of that will depend on the context. So for example, in the neoadjuvant space, it's maybe trickier because you're really eager to start treatment, a curative intent treatment. In the adjuvant space, there's time. You've just had a surgery. These patients need time to recover. So in my mind, I think that's actually an ideal time to think about, taking the time to develop something that may be tumor-informed. So I think that there's going to be factors also, related to these vaccines as to where they're specifically being utilized and how that will play into the kind of feasibility of doing that.
Great. Okay, well, we're out of time. So Justin, Rebecca, and Zosha, thanks so much for the panel today. It's been a fascinating discussion.
Thank you.
Thanks, everyone, for attending.